This week on the BackTable podcast.
And speaking of biopsy, we all know that the good thing is HCC a lot of times something that we can make a diagnosis based on imaging, right? Arterial enhancement, venous phase washout, pseudocapsule. We actually do biopsy when the imaging is not diagnostic. Like there's certain things like no venous phase washout or something, we do biopsy. So far, like the cases, like my patients, everything is safe, right? We traditionally think that HCC is a very hypervascular tumor. With biopsy, there was always bleeding risk, right?
Hey guys, welcome back. It's our next episode of HCC BackTable discussion this weekend. So in our first discussion, we spoke about first-line therapies for HCC, where thankfully now we have a lot of good prospective data and good options. Currently, the second-line space is a little bit murkier, shall I say. I think there's been this thought of just ICI has kind of taken first line and we just pushed all the old first line regimens into the second line. But I think that's what I want to discuss with you guys and kind of name a few of the players on the scene and see where the data supports and where we don't have data. So, previously, we had Lenvatinib and Sorafenib in the first line and agents like Regorafenib, Cabozentinib, and then Ramucirumab for a specific population in that other second line population. So how are you looking at this? Is this something where you feel like there's no man's land, there's no data, or do you find any data that from these real world analyses that have kind of pushed you to using one agent over the other? Or what are you thinking?
I usually will use Lenvatinib second line.
And that's regardless of what you use first line, or is that if you've used Atezolizumab or Stride, or is it across the board?
Regardless, because even if patient progress on Atezolizumab, we're like, oh, the remaining treatment options are all either TKI or Ramucirumab, which I feel that's like this VEGFR2 inhibitor, so very similar to Bevacizumab as well. So my personal use, I always go to Lenvatinib as second line.
Craig, do you have a different approach?
I think differently on this one. It's pretty much going Lenvatinib. I would say 9 times out of 10. If I did Stride first line, so this person's never had, if Atezolizumab and they progress, I'm not going to use Ramucirumab second line. They've already had essentially Bevacizumab's newer cousin. Bevacizumab the original and Ramucirumab just a newer cousin of that. If they had Stride first line and the AFP is elevated enough, I'm doing Ramucirumab second line. That's probably the only setting that would go away from Len. Every now and then, as I said, I'll consider doing CTLA-4 in the second line because I didn't get it first line. So 8 times out of 10, it's Lenvatinib. The other one will be a Ramucirumab because they got Stride first line and they have an elevated AFP. And then the other times being this tumor is a little bit scary to me. It's growing a little bit fast and blowing through Atezolizumab. Then I'll try something involving a CTLA-4 inhibitor in the second line. So 8 out of 10, I would say. And then, the other 2.
That's pretty good for batting average. It'd be very good. Yeah. So AFP greater than 400, we know is the kind of criteria and NCCN and the approval for Ramucirumab. So that's an interesting thought. I usually don't go to Ramucirumab second line, but I hadn't thought about it as maybe a potentially good option for those patients who hadn't gotten VEGF in the first line. So actually kind of piqued my interest a little bit too. So yeah, I agree that I think Lenvatinib is a sensible second line. Is Cabozentinib on the agenda? Is Regorafenib there, or those kind of fall to beyond progression on perhaps Lenvatinib?
Usually if they progress on Lenvatinib, I will use Cabozentinib.
So Cabozentinib kind of falls to that third line after progression on Lenvatinib for you.
Right. But realistically, what's the percentage of our patients who ever even get to third line, right? Yeah. Usually I think second line is the best that they can get.
I again, not feel differently that much. Again, I don't have a ton of reason to feel differently, but many, many years ago, before Cabozentinib was a thing in HCC, we did some of the clinical trials with Cabozentinib with the dose-finding clinical trials when I was at Washington University when I met Lingling. And man, Cabozentinib was hard. I found a lot of trouble, and I can't imagine giving a third-line HCC patient Cabozentinib. And so for those patients, I'm trying, Sorafenib at that point. That's that's what I'm trying then. Just
So sorafenib over cabozantinib in the third line.
Third line.
Gotcha.
Correct. Again, my only rationale being prior experience with Cabozentinib, that I thought it was very, very hard to give. I have a lot of experience with regorafenib from colorectal and stuff like that. So again, very comfortable with that. But again, the absolute indication has to be somebody that actually tolerated sorafenib well. So that's sort of seals it for me to go to sorafenib rather than Cabo or regorafenib. But I would love to say I have a huge amount of scientific data to back that up, but it's just some of it's experience, some of it's third line is it's so hard for those patients. It is so few and far between you get a patient that's able to.
And
do
I feel that like different people tolerate different medication completely differently as well. I would say I hardly had patient who could tolerate a full dose lenvatinib or cabozantinib or anything. But I only had one patient after all these years, like full dose lenvatinib, no problem at all. And then full dose cabozantinib, no problem at all. And of course, progress again. And I gave him sorafenib. Yeah. And then he's like, this pill is too hard for me.
Interesting. So one of the themes y'all are getting at is that just the number of patients that you're getting, even to make it to second line, is not high.
Correct.
And then furthermore, even the third line. And there's two factors there. One is their performance status as their cancer progresses. The other is their liver function, which we alluded to in our previous episode. So to capture these patients is hard enough, and to then get enough experience to say, okay, this is always my go-to third line. I mean, we just don't see enough patients to get third line therapy, I think is the bottom line. What about the patients who you start on Atezolizumab? Both of you mentioned that that's kind of, in at least half of your patients, that's your first line therapy. Let's say 2-3 months, their AFP's quadrupled and they have, several new metastatic lesions. Is that someone you are thinking about differently than someone who's maybe had a 9 to 12 month course with Atezolizumab and then you're reaching to lenvatinib? That person who really blows through quote unquote first line therapy, are you still approaching them the same way you would that other patient?
I think this question is probably asking, like, if a patient blows through frontline, say Atezolizumab, do we feel that we should try maybe a double ICI regimen, adding a CTLA-4? Is it worth, although they're resistant to PD-L1 blockade, should we try adding the CTLA-4 blockade to see if that can overcome the resistance?
That's what I'm getting at here. Thank you for speaking for me. Have you tried that before?
I haven't tried. I mean, again, taking each patient into account, it probably depends on, what remaining performance status they have. If you still feel like they have pretty decent performance status, sure. If you feel like they're declining, again, you might just go with the TKI at that point. Although, those are not like those are wonderfully tolerated either, but it's probably having something to do with what performance status they have and those kind of things. But if it's somebody that I'm inclined to be aggressive with, would probably be, as I said, adding CTLA-4 to a PD-1.
I've tried that. Not a lot of times, but several times. I think the bottom line is, if they are blowing through frontline Atezolizumab for any immunotherapy, that's a bad sign. Yeah. To begin with, that's a poor prognosis sign. So the few times that I tried, I would say adding CTLA-4, it either not worked at all or worked very, very transiently.
Have you ever done the opposite, where you've started someone on Stride and then gone back to Atezolizumab?
I have not. The closest, as I said, is coming with Ramucirumab second line. That's the closest that I've come to.
I would say, like, if you want the anti-VEGFR from the Bev, you can, like, TKI, same thing.
Yeah. All right, I'm going to give you another scenario. Someone's on Stride. They have good disease control for 9 to 12 months and then start to develop some progression. What's your thought about A, switching to second line lenvatinib, or B, giving them another priming dose of tremelimumab? Have you done that before, since that was technically allowed on the Himalaya trial?
I've tried that.
With any success?
Either no success or transiently. But of course, I'm not talking about, I've treated 100 patients that will re-challenge. It's a very, very small sample size. So, but I'm actually not opposed to that. I think it's reasonable.
Yeah. The patients like it. Rather than saying that you're giving up on immunotherapy that they've done well on, and then that you're going to go do something completely different. They like the fact that you're trying to reprime with CTLA-4 again. That's most of them have liked it. It buys you 2 months of, of treatment before you have to do the scans
Switching,
and make a decision one way or another. And in general, I can't say it's been successful, but in general, the first scan is like, oh, it's not shrinking, but at least it's stable. And then, so usually they'll get 2 to 4 months of feeling decent before you have to give up on it and go to something else. So it does buy me a little bit of time to think about what my strategy is going to be, what's best for this patient, are there clinical trials, those kinds of things. It's a little bit of a buying time. I haven't had a tremendous amount of success with it, but it has been done. And again, in most cases, it's been sort of 4 months. I get 4 months before I have to actually, okay, this is not working. Now we need to do something different.
Yeah, I agree. I mean, I don't know that I've had any home runs in terms of success with it, but I think patients, if they're on the stride for that long, they're usually tolerating quite well. And the extra tremi, in my experience, has not caused any undue toxicity, again, in my limited experience, especially if I'm thinking about maybe a second line trial and I maybe it's not open or we don't have any slots. And you're like, well, if I just, if we could postpone this progression for another 3 to 4 months, perhaps that would be, then we could put you on that trial. So it becomes a kind of an interesting way to also game it where you can keep them on that first line therapy a little bit longer. When you are using Lenvatinib, we talked about Cabo and full dose. I mean, I will tell you, when I ever use Cabo, I never start at 60 milligrams. I have not met the patient yet who can tolerate 60 milligrams of Cabozentinib. Are you reaching for 12 of Lenvatinib? Are you starting with 8 milligrams? Kind of what's your approach for the average patient who, obviously if, they come in, their borderline liver function and performance status is 1 bordering on 2, maybe you're going to start them lower dose. But for the average patient, are you starting a lower dose or starting them at 12?
So for all these HCC TKI, start at 1 dose lower than the recommended dose. So for Lenvatinib, I start at 8.
You find that to be the sweet spot for most patients? Or are you still dose reducing further?
It really depends. I feel that the way that people tolerate TKI, some people can tolerate it. Some people can bite their teeth and tolerate it. I've also had patients take it for 3 days and had to stop because they couldn't get out of bed.
Do you find any of those patients are able to tolerate a different TKI any better? Or kind of if they didn't tolerate Len, you feel not optimistic they would tolerate Cabo or Sorafenib?
I think they're pretty similar.
Yeah. Craig, do you have any different thoughts in that area? Or?
I think very similar. I try to start at 8, and 8 in general has been decently well tolerated. I can't think of some. I'm just, as I'm sort of scrolling through my brain trying to think of, have I had anybody tolerate 12? I don't know that I've had anybody tolerate 12. I would say 8 is probably where things fall out the most. Just common things being common. As I said, I probably have more experience with regorafenib than any of the other TKIs combined, and so that one I'm very, very comfortable with all the different contortions that one can do with TKI dosing with that probably more than any of the other ones. But I think with Lenvatinib, it's usually, I would say, regression to the mean is somewhere around 8 for most of those patients.
What about your use of NGS in these patients? So I think this is the one disease that at least I treat where NGS does not play a major role. So next generation sequencing is what I'm getting at. I know you guys know what I'm talking about, but my policy in literally every other cancer, certainly the advanced setting, is I'm not treating you properly until I know exactly what your molecular profiling is showing.
Right.
But in HCC, for a variety of reasons, one is because we really don't have a lot of biomarker-specific targeted therapies, and the other is that we often don't have tissue. What's your use of that? Craig, since you don't practice with me, I kind of know what Lingling's answer is to this. But I'm kind of curious if this is institution variation or, but do you get NGS? What percentage of your patients do you have any kind of molecular profiling on with HCC?
Yeah, so for HCC, it's relatively low. If you were to compare it to the other GI cancers that we care for, it's relatively low. Again, some of it is a starting point because, quite often the patients don't have a biopsy. I've been thinking about that more, whether I should biopsy the patients, not for diagnostic purposes, but just to have something, cooked and banked so that I can consider things down the road. Now, I'm not in the few patients with HCC that we actually have checked. I didn't find anything. So, it's sort of, what is the value of doing it? Nowadays, there are some of those circulating ones where you don't need to have a biopsy to come up with what the molecular changes that are going on within the tumor. You don't necessarily need to have that information. And so I have used those a few times. Have I found anything? No. But still, we don't necessarily have to do the biopsy to try to get some of that information. And on top of that, the clinical trials will accept blood-based assays for enrollment most of the time. But I'm still looking for my first HCC patient that has something that I can actually use, a therapy that's outside of the box as far as what's already approved.
I remember I talked to you about this several years ago. At that time, of course, we had immunotherapy already. At that time, I was like, in other cancer, right? Like we do NGS, like every single one. What do we find that can help us if they're, say, MSI high or tumor mutational burden high? Then we can use immunotherapy. If they have like certain targets, that we can use certain target therapy. And what are we using to treat HCC? We are using frontline immunotherapy. So I'm treating you with that already. And then guess what? I'm using second line, so TKI. So I'm targeting multiple targets already. However, ever since then, I would say over the recent years, I'm doing more and more ctDNA. Has it ever helped me? No, it has not. The majority of the mutations that I get is not something targetable, right? We just know, okay, you have this. Okay, now no. The only one time that I had BRCA2 mutation and I treated a patient with PARP inhibitor and it didn't work at all. So it never helped me. However, I'm still doing, like, if patient have a biopsy, I would do NGS. I'm still doing CT, and so that I know, especially I think, like, right now, there's tumor agnostic regimen that is approved, right? If they have RET mutation, if they have, like, NTRK mutation, they can use those. But is it common in HCC? It's rare, and I haven't found one yet.
Right. So, yeah, for RET and NTRK fusions, they do have tumor agnostic approvals. If you look at the NCCN guidelines, they are there. Also is MSI high. So, it's interesting that those are commented on, but again, most patients, obviously we don't see them commonly. And then for MSI high, I actually had a patient I saw who underwent one of the few that actually had an upfront resection. We do a lot of transplants, but, her liver was otherwise healthy. It was actually found through a multi-cancer early detection test. So Grail's Gallery test. Yeah. And she had upfront resection, and her pathology showed loss of MLH1 and PMS2. And I was like, okay, still not going to give you adjuvant.
Probably have a BRAF mutation as
she
well.
She might have. They probably reflex just because that's suited for colorectal. Right. But, I wasn't going to give her adjuvant because I think the data on adjuvant is not supportive of giving adjuvant therapy. Right. I think we've established that at this point. But I was like, hey, if the cancer comes back, we're going to give you immunotherapy, which we would have done anyway. So I'm not sure what the value of that was, true. But it was interesting. And I remember when I, probably about 5 years ago, I had a patient who had a biopsy. So again, most of our patients we don't have tissue on. And he had HER2 amplification. It was 3+ on the biopsy. So I actually did give him HER2 trastuzumab deruxtecan as maybe a second line therapy. I think it wasn't an initial therapy, but he did not have any response to it. I don't think there's been a lot of reports of HER2 overexpression on HCC and what the significance of that is. But obviously, when you're getting to second and third line, it's not like we had great options anyway. In our next episode, we're going to discuss a little bit about future and clinical trials and where HCC is headed. But one thing that I think is we have to think about is that since we don't have tissue on these patients and the future of oncology trials are mostly biomarker driven, what is that going to mean for our HCC patients? Should we just be biopsying them? Should we only do it in a trial situation? Maybe there are markers and we're just not looking, though I'm a little skeptical of that.
Or maybe we do ctDNA on the majority of them so that we have all those data. Then maybe I know that there's certain mutations that we're seeing more commonly with HCC. Then maybe eventually one day we'll have target therapy targeting these targets.
That was going to be my question to you all was, how do you feel about biopsies going forward? But it sounds like maybe ctDNA might be good enough to try to get the answers to what we're talking about here, because mostly, again, all the TKIs are targeted. I mean, when you think about sort of FGF, when you look at the TKIs, it's in there. It's targeting VEGF, it's targeting FGF, it's targeting RAF. I mean, there's all kinds of things that are in the multi-kinase TKIs that I don't know that the testing is going to give us much, but I didn't know what you all's practice was. You thought going forward.
And speaking of biopsy, we all know that, like, the good thing is HCC a lot of times something that we can make a diagnosis based on imaging, right? Arterial enhancement, venous phase washout, pseudocapsule. We actually do biopsy when the imaging is not diagnostic. Like, there's certain things like no venous phase washout or something, we do biopsy. So far, like the cases, like my patients, everything, everything is safe, right? We traditionally think that HCC is a very hypervascular tumor with biopsy. There was always bleeding risk, right? But
and tumor seeding is the other concern, right?
Right. And then, but I did had a second opinion patient sent to me that had a biopsy a long time ago because, again, it was not typical. They could not make the diagnosis based on imaging study and did have bad bleeding, like very bad bleeding, hemorrhagic shock after the biopsy. And then the patient actually was a Jehovah's Witness. Like he survived, but still that was a very traumatic experience to him. So I do feel that the risk of bleeding is real. It's not something that will like never happen.
No, absolutely. I mean, I think if it becomes important through some new clinical standard of care that we have to offer a patient, or we want to roll them on a trial, then we'll have to start doing it. But I think as long as there are no quote unquote, biomarker targeted therapies, even though we use target therapies, but in the colloquial sense, we're not in a huge rush to do it. Sometimes we'll biopsy metastatic sites just to prove it's a lung nodule we're not sure about, a bone lesion we're not sure about. But I think by and large, we're not doing as many biopsies as we did for other GI malignancies.
Okay.
So I think that about closes out our discussion of second-line therapies for HCC. Do y'all have other points you want to make or other clinical scenarios that
I was going to have a question for you all. So, one of the things, there's some clinical trials that you hear about that are combining second-line immunotherapy with TKI. We know that, we know what the first line experience has been, although there's some other ones out there that have been done in other countries that look positive. And the other question that comes up quite often is continuing immunotherapy after, like what we do with colorectal, with continuing Bevacizumab.
Anti-VEGFR, right.
And so I would say, I get this question from patients all the time is, should we continue the immunotherapy and add the second line therapy in there? Or what do we consider about TKI plus immunotherapy? And they're kind of two parts of the same question. Second line immunotherapy and TKI, even though we know it doesn't work in the first line, I guess it's sort of the question is, how convinced are you from the first line data that whether second line should be useful or not? I would ask both of your opinion on that.
Yeah, I'm a little skeptical. I mean, I think you're not adding a lot of toxicity, right? Most people, certainly if they've been exposed already to PD-1, they're going to continue to tolerate PD-1. TKI has its own side effects, but they're pretty distinct from what you're getting from the immune checkpoint inhibitor. I don't think there's much risk in it, but there's the financial toxicity, of course, and obviously getting it covered. I'm not terribly optimistic, though there are some ongoing prospective studies looking at this exact question. If it turns out to be positive, don't get me wrong, I'm gonna be the first one running to prescribe it, but I have certainly not adopted that as for my practice of continuing ICI in the second line setting. Though I have had patients ask me that too. I don't know about you, Lingling.
Oh, yeah. I definitely had patients just because immunotherapy is so easy. They're like, can I continue with it? Of course, in clinical practice, if they progress on immunotherapy, we're doing TKI, we're not combining both. But that question to me, the root of that question is, to me, something that really amazes me is what's the mechanism of resistance? Like what make them like the intrinsic resistance? Like if you give them frontline immunotherapy, they don't respond at all. Why is that? Why are they so cold and not responding to immunotherapy? Or, like you said, they respond in the beginning and then they start progressing. Like extrinsic development of resistance, what's the mechanism behind it? To me, I still don't know. Like after developed resistance, what is driving the resistance and how can we overcome the resistance? How can we turn a immune cold tumor in HCC into a immune hot tumor? Is adding the TKI on top of immunotherapy the right answer? I don't know.
Well, I mean, there is data that TKIs can alter PD-L1 expression. That's been established a long time ago, but I don't know. Is it in reality, is it working?
Yeah, that's why they combine Atezolizumab with Bev, is they feel that the Bev can up titrate the expression, right? But if they progress on that, like combining both, would it work?
Yeah. And I think also from a patient perspective, I think immunotherapy has this mystique, right? It's, there's chemo, there's targeted therapy, but, something that could really provide you long-term potential survival is immunotherapy. And that's why I think a lot of patients are like, can I just continue it?
Yeah, plus it's your own immune system. We're turbocharging their immune system to fight their cancer. And there's something very attractive about that, you're not giving, like chemotherapy, where you're giving them some foreign thing. You are giving them something foreign, but you're punching their immune system and turbocharging it to attack their cancer. And that inherently there's some coolness and a little bit Star Trek-y things with that.
Well, I mean, I see that. I mean, in the current environment of some of the conversations we have to have in our clinic that probably come from some politics where people have some questions about, is this poison? You know, why are you giving this to me? I do think there are patients who are a little bit more open to immunotherapy because it is utilizing something that is intrinsic to your body to fighting rather than a direct
external
toxin.
poison.
Yeah,
exactly.
So that's a great point.
They when I talk about that with them, they love it. That's a selling point.
Yeah.
To for them to get more enthusiastic about it. That this is their own body fighting the cancer.
Yep.
That's actually the point that I'm focusing on when I'm talking about side effects.
Is it? Okay,
Right.
well, yes. There's that too.
Right.
Well, great. Any other comments before we close this session? Okay.
Thanks for having us.
All right. We'll keep working on second and third line therapy for HCC, but I appreciate the conversation. And that'll be it for this episode.
Thank you.
Thank you.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.